on immunotherapy, uh, and um, and it's a very hot topic. The immunotherapy won a Nobel Prize, the investigators behind it, and has become another major treatment option for patients with cancer. Um, and so I most recently reviewed medical literature. My name is Dr. Sandeep Bhave. I'm a radiation oncologist. I practice at Franciscan Health and as part of Cancer Care Group in Mooresville and in Indianapolis at the main campus. And I've also done research with immunotherapy back when I was at the University of Chicago. I have no relevant disclosures, and I'm not being paid by any of the drug companies. But basically, I wanted to go over what is immunotherapy, when is it right for a person with suffering with cancer, and what you should know about the clinical trials, the different kind of immune therapies that exist, because it is a relatively general term. What kind of side effects can patients expect, quality of life, as well as the future, and take the opportunity to answer any questions that you may have. So what is immunotherapy? Immunotherapy is a type of cancer treatment that uses the body's natural immune system to fight cancer. Generally, before this technology and therapies were developed, cancer cells would hide from the immune system. And immuno-oncology is a field of cancer research that has existed for the last, since the 1960s, 1970s, that works to understand how the immune system interacts with cancer. And only until recently have we figured out ways to really harness the potential of using the body's immune system to fight cancer. Our immune system, as we've come to know, facing the pandemic and other things, is really vital against protecting against diseases such as bacteria and viruses, as well as abnormal cells that can form cancer cells. When a virus enters the body or bacteria, it tags extra information on the top of a normal human cell. And then the immune system can say, hey, that's not normal, and attack it. Those tags that are on the surface of a cell are proteins, or they can be sugars, or they can be fat cells, and they're called antigens. The immunotherapy treatments fight cancer by boosting the immune system, and they work to basically remove the camouflage and allow cancer cells to be marked. And they can help the cancer cells, find cells and deliver treatment directly to cancer cells. And generally, they're given through an intravenous infusion. An IV is made. It's done in an office or a cancer center clinic, usually on an outpatient basis. So usually people do not have to be admitted for this type of treatment. It's given on various schedules, meaning it can be given every 2 weeks to up to every 4 weeks, sometimes every 3 weeks. That's usually the general range. And sometimes it's combined with other treatments, such as with chemotherapy or with other targeted therapy that's not a chemotherapy. So as I mentioned earlier, the immune system kind of works with cells, tissues, and organs. A bunch of cells make a specific tissue, and all those tissues together make a certain organ to fight the body from different bad things, as well as abnormal cells. A type of immune cell that's important to understanding this talk is a T cell. A T cell is a very important immune cell that can basically distinguish self from not self, or normal from abnormal. And when they do, then they send other information to other cells, such as B cells, to create antibodies. But T cells are very, very important to identify. They're kind of like the site for our immune system to see whether something is abnormal. And an antibody is what is eventually made by the immune system through various different cells to attach to the bad guy, such as the bacteria, the virus, or to cancerous cells. And the way we can tell the difference is through these tumor antigens, or abnormal features of cancer cells that are different from our normal cells. And a biomarker is basically a way that doctors like me can measure and say whether a patient is a good candidate for certain treatments, such as immune therapy. So if you are receiving immune therapy or will in the future, as well as any real cancer treatment, it's important to let your healthcare team know right away if you develop side effects. Because while immune therapy in general has a lower side effect profile, it doesn't work for everyone, and side effects, if they occur, can be significant. And it's still an active area of investigation. Things that researchers are trying to answer is, we know that immune therapy, when it's effective, can be really a game changer in somebody's quality of life and in life expectancy in general. But not everybody responds, and we don't quite know why. We're trying to investigate whether combining different therapies, such as radiation with immune therapy, or adding chemo with immune therapy, or other immune therapy with immune therapy, can that improve the outcome? Are there certain types of patients that do better with immune therapy versus not? And when do we give it? And since it's relatively new, in the last 10 to 15 years, we still are sorting out the long-term side effects of people who have immune therapy. So many patients who are listening to this talk might say, wow, this sounds so promising. Why am I not getting immune therapy right now? Well, in general, most patients who are receiving immune therapy today have cancers that are in the advanced stage. So in stage 3, unresectable lung cancer, it is standard of care, for example. In metastatic, many metastatic cancers, which I'll talk about later, it is a standard treatment option, either at initial diagnosis or after the initial diagnosis, for whatever reason, doesn't work as the oncologist hoped. But new approvals are happening in many cancers, and have approval in certain early stage cancers. And we're still sorting it out. One key contraindication, or patients who cannot get immune therapy for the most part, are patients with certain autoimmune disorders, such as severe, like symptomatic lupus, Crohn's disease, ulcerative colitis, and other autoimmune diseases that are a little less common. So it really takes a team-based approach to determine whether immune therapy is right for the patient. But with any drug that's new and carries a side effect profile, as well as an antibody treatment, which takes a lot of time to develop and manufacture, these drugs are quite expensive. And those that are getting treated as part of your clinical trial may have costs covered, but making sure that the physician has approval to give treatment is critical, but is usually a standard part of most oncologists' practice to make sure that we don't cause undue financial toxicity to the patients we take care of. But I think it's important to know what the cost would be, to you, if insurance is covering it. But there are access programs that exist, and many of these drug companies do try to reach out to help provide, therapeutic therapy to patients who need it. And when clinical trials are available for patients, in general, it is the preferred option. That is the mainstay for most cancer centers. If you have access to a clinical trial where they randomize between a standard treatment or a new investigational treatment, that's the way that science has moved forward. And also, patients on research studies in general tend to have the most meticulous follow-up imaginable. So in general, people who are on research studies tend to have the best outcomes for any cancer patient. So I think it's always good to ask whether clinical trials are an option for the cancer that you have. And it may be one of the ways to get the most promising and used drugs. Obviously, because it's in a trial, it's not known whether there's a benefit, but there's something called equipoise, meaning we don't know whether it's going to cause benefit and we don't know whether it's going to cause harm. So that's why it's being studied. But there's hope that it will provide benefits. So participating in a clinical trial, I think, is really important. In patients who enroll on a clinical trial, especially in randomized clinical trials, which is the gold standard to prove whether something works or doesn't work, and the basis by which FDA approval is given, one group of patients receives the standard treatment. So they still get everything that is indicated for that cancer that the patient has. But in the other group, based completely randomly, the investigator doesn't, the doctor doesn't know, the investigator doesn't, blindly picks, they get the therapy. And not every center offers the same trial. So if there is an advanced cancer, or if there are, if you do have an interest in clinical trials, be sure to ask the physician whether there are clinical trials in the area that, and then, it's the responsibility of any cancer doctor to kind of look into that and make sure that the patient's answers or questions are answered. And most of the time they pay for the cost of the drug study, but be sure to ask the healthcare team what costs are involved when enrolling in a trial. There are many kinds of immune therapies. The most common one that most patients are, if they are eligible for immune therapy, are going to be checkpoint inhibitors, which I'll talk about more in a moment. There are other monoclonal antibodies, which means they're made of one clone. They're all the same, it's like it's like a factory of everybody making Pepsi the same way, meaning the antibody is made the same exact way. That's why it's called a monoclonal antibody. Cell therapy, cytokines, cancer treatment vaccines, and oncolytic virus therapy. So I'll spend a good amount of time talking about checkpoint inhibitors, as this has really changed immune therapy quite a bit. Basically, the immune system has gas to make it go, to activate the immune system, and safeguards to prevent it from overreacting. If you have the immune system not working at all, for lack of an easy way to think about it, is like the boy in the bubble. Nothing, you walk outside, any little bug can cause an infection. But at the same time, if the immune system is too revved up, you can get an autoimmune disease, such as lupus or other conditions. So having a balance between the two is very important. And everybody might have experienced, after having any vaccine, that feeling of feeling a little bit lethargic or tired afterwards. And that's because the immune system requires a lot of energy. So having that balance between the two is really important. But cancer cells take advantage of that. They trick the body into turning down its defenses. And checkpoint inhibitors help block, prevent cancer cells from forming. So shown here, I'm gonna do my best to explain this. So basically, you can see here, there's the cancer cell. This is the bad guy, okay? And cancer cells express special kinds of proteins or tags on the surface right here of the cell that a T cell, the immune system, can identify. But it also has this receptor called PDL1, program death ligand 1. And what that means is, if that is on there, it tells the T cell here, no, don't make immune cells, turn the volume down, don't activate here. And so this causes upstream T cells to say, okay, we're not going to make more T cells anymore. We're not going to be looking for bad guys anymore. And it's going to tell the cancer cells, okay, you can keep growing. We're not going to stop you from dividing. In immune therapy, the antibodies here that target either the PDL1 receptor on the cancer cell or the PD1 receptor on the T cell block this process. So basically, they cut the gas line, or they cut the ability for them to hijack this operation. And so now the T cell receptor knows, hey, this is a bad guy. I'm going to fire everything I got at it, meaning I'm going to go and make antibodies. Okay, and then the antibodies can then fight the cancer cells. Or by activating here, they'll send signals to say, this cell, you can die now, cancer cell. And so that's how, in a nutshell, how these work. And it's been a true game changer. The two most common kinds are the checkpoint inhibitors that target either the PD1 on immune cells or the PDL1 on cancer cells, or CTLA4 inhibitors, which essentially work the same way as PD or PDL1. It was the first generation of immune therapy, primarily used in melanoma, and is called, the name is Yervoy or Ipilimumab. But there are a host of PD1 or PDL1 inhibitors, and you can see a list below. There, every day there's going to be more of these. But the big ones are pembrolizumab, Keytruda. This is a Merck antibody, and it is used in many different types of solid tumors. Durvalumab or Imfinzi, which is used in stage 3 non-small cell lung cancer after chemoradiation. Nivolumab, which is used in a whole host of cancers, including lung cancer. Libtayo is used in cervical cancer. Tecentriq is used primarily in small cell lung cancer, and avelumab isn't used as frequently, but is used in bladder cancer. But as shown on this slide, this is from the Cancer Research Institute. The indication shown here on the y-axis is the year, 2014, 2015, and so on and so forth. This is the most recent year. And these are the different solid tumor types. As you can see, the indications are just growing by the year. And similarly for non-checkpoint inhibitors, so non-PD-1, PD-L1, there are many different types of immune therapies that are getting approved each and every year. So it's very exciting. Like I mentioned, checkpoint inhibitors are used in a host of different types of cancers, and here's a list. A lot of different solid tumors are candidates for them. Most commonly, we think of melanoma, lung cancer, colorectal cancer can be used in, cervical cancer, recently endometrial cancer. In the advanced setting, it's been approved for, as well as triple negative breast cancer just this year. And in Keytruda, the Merck antibody that I had mentioned earlier, it's also approved in patients who have something called Lynch syndrome, which is a type of genetic syndrome where they form, they have DNA mutations that make them more prone to forming cancer, but at the same time also more prone to having an incredible response from immune therapy. So Keytruda can take advantage of that, and it's approved for any kind of tumor that has defects in mismatch repair, which is the type of DNA repair that I just talked about, or microsatellite instability high, meaning they form these DNA damages. Patients form these DNA damage is more commonly. And so that's very exciting. Avelumab, as I touched on earlier, is used in some patients with Merkel cell cancer as well as bladder cancer. And pembrolizumab is used in, probably has the most indications. It's either between them or nivolumab, but probably Keytruda does. And you can see the list. It's very exciting. Nivolumab similarly is used in a whole host of, has some similar indications as well. And atezolizumab, Tecentriq, is used in urothelial cancer, but I think of it as a big workhorse and game changer in small cell lung cancer. It's become, part of it's become part of the standard of care for patients with advanced small cell lung cancer to receive Tecentriq, and it's made a huge impact on how on survival and chances of progression. Durvalumab, as I touched on earlier, is also a PD-L1 inhibitor, and it's been a game changer in advanced or stage 3 non-small cell lung cancer. In most patients with stage 3 non-small cell lung cancer, they get chemotherapy with radiation combined, and that's used for curative intent. And that's been the standard of care for the last 20 to 30 years. But outcomes have not changed much. With the addition of the immune therapy, we've seen some of the best outcomes ever. And it's caused some of the biggest improvements in survival in the past several decades. And it's hypothesized that basically when the radiation and chemotherapy are given together, that when the cancer cells die and the immune therapy is given, you're basically creating a vaccine inside of you. And so with the immune therapy revving up the immune system, revealing the cancer cells, the antibody response is so profound that patients do substantially better. And I'm seeing more and more patients with stage 3 lung cancer doing outstanding. I touched on Libtayo. It's used in patients with non-small cell lung cancer. It's used in advanced cutaneous squamous cell carcinoma who can't get curative surgical resection or radiation therapy. But it's also just been recently approved for cervical cancer. And it's an exciting treatment option for these patients as well. I touched on Ipilimumab earlier. It's a CTLA-4 inhibitor, and it's used in different cancers. It can be used in melanoma, but it's less frequently used than it was in the past with the advent of, nivolumab and, Opdivo is used more commonly. But sometimes the combination is given in colorectal cancer, Opdivo, nivolumab with Yervoy, or in kidney cancer, or in the combination can be given also in non-small cell lung cancer. But you have to carefully choose the patients carefully, and there has to be a good discussion between the doctor and the patient about the risks and benefits of combining the two, because when you increase the gas on the immune system, you have to make sure you can still turn the car. And sometimes if the immune system is too revved up, you can have higher risk for side effects. So that's one thing to keep in mind. Checkpoint inhibitors, as I kind of touched on earlier, may be given with other therapies like chemotherapy, and very commonly in lung cancer, the standard of care, essentially irrespective of your PD-L1 status, unless it's very high, is to get chemotherapy with immune therapy. And like I mentioned, checkpoint inhibitors are being studied with radiation, and my research when I was at Chicago focused on it, and it's a very, very active area of research right now. There are other antibodies that exist, and other types of antibodies are going to be less commonly seen, but they work similarly. They use the immune system to find cancer cells, but some of them, they're also targeted treatments too, and these are primarily used in liquid cancers, meaning leukemia or in some cases lymphoma. For example, you can see a list here in acute lymphoblastic leukemia, acute myeloid leukemia, and chronic lymphocytic leukemia. These target specific CDs. So these are certain cells on white cells. We have white cells and red cells. White cells are the immune system. Red cells are blood cells. And these different antibodies can target these different antigens, because CD19 is a type of antigen, so that it can attack these specific leukemia cells preferentially. And so that's an active area of investigation. One of the most common ones that you'll see here is rituximab, or Rituxan, which is used in a whole host of B-cell lymphomas as well as leukemias. Hodgkin's lymphoma, a big breakthrough is brentuximab vedotin. which has a monoclonal antibody attached to a chemo drug. So it's kind of like a heat-seeking missile. It'll find the bad cells for Hodgkin's lymphoma, and then it's attached to a bomb, which is the chemotherapy drug. And there's a whole host of other ones that are being investigated. Non-Hodgkin's, like I mentioned, rituximab is used very commonly. Rituximab also can be used. And in multiple myeloma, daratumumab is used very commonly. And so let's talk about boosting the immune response through cell therapy. In cell therapy, you take your own cells and they're removed, taken to a lab, modified, and then placed back in. One of the most exciting treatments that exists for that is called CAR T cell therapy. There are two kinds here of CAR T cell therapy. Basically, you take your own cancer cell, your own cells, including your own T cells from the blood, take them to the lab and create something called a chimeric antigen, where you combine your own T cells with the cancer cells. So that way, when the T cells go back into the system, you have a super immune response to find and attack the leukemia cells. And it's used primarily in leukemia as well as in recently diffuse large B-cell lymphoma, but it's being studied in other cancer cells. It's even being studied in brain tumors, like in glioblastoma. So there's a lot of exciting investigations that are looking into this type of cell therapy. Cytokines are the things we feel after a vaccine. How people say, man, I feel sick after a vaccine. The vaccine made me sick. It's really the release of these cytokines. These are different growth factors or stimulating factors to make the immune system work. They speed up the growth and generate and boost the immune system in general. But that requires energy, so that makes people feel pretty tired. Most common ones done are interleukins and interferon. They've been used in melanoma and in kidney cancers, and they are effective. But generally they do require hospitalization because people feel pretty sick with them, and they require inpatient care to make sure that everything is done safely. But it's still another kind of immune therapy. There are also vaccines, cancer treatment vaccines. One of the most common ones is the one that I tell all my patients about, and especially if they have children, is we have a cancer vaccine. We talk about it on TV. We say, when will be the day that we won't have X kind of cancer? Well, that exists for a couple of cancers already. Hepatitis B, you get that vaccine, your likelihood of getting certain kinds of liver cancer goes down significantly. We know that. And if children, before the age of 12, 9 to 12, get the human papillomavirus vaccine, the risk of getting cervical cancer, as well as head and neck cancer and other kinds of cancer drops significantly. In Australia, where it's commonplace, where almost everyone gets the HPV vaccine, it's extremely uncommon to get these kinds of cancers. So we're already kind of seeing a change in how common it is in worldwide. And something I want to let you know that, if you do have children off the age that are eligible for the human papillomavirus vaccine, I strongly recommend it because it is a cancer vaccine. And then there's also something called Trving. It's used in prostate cancer in certain settings. And in early stage bladder cancer, BCG, which is used as actually a vaccination for tuberculosis around the world in areas where it's more common, is also thought to create an immune response. So for the past several decades, it's used to treat early stage bladder cancer by causing this general immune response. And with the combination, most patients are, out of every 4 patients, 3 are cured and don't have the bladder cancer come back. Oncolytic virus therapy is another investigational type of immune therapy where you use viruses to fight cancer cells. So basically think of taking the common cold, mutating it, and then having it have a special package so that if it infects a cancer cell, it kills the cancer cell. And this is an active area of investigation. It's being studied in a whole host of different cancers, but it's currently approved to treat melanoma. While immune therapy is very exciting, it also comes with real side effects that I need to mention. Immunotherapy may be thought of as a natural ingredient, but this isn't echinacea. This is medicine that can have real serious side effects. But they're different from chemotherapy or radiation therapy. Sometimes it can be just as simple as fatigue, but sometimes it can be life-threatening. Common side effects, like I mentioned, when people get a vaccine or sometimes are just getting over a cold, they have their immune system is in full gear, so they don't feel great. They can have a headache, can have cough. You could feel tired. That's really really the biggest one here. Some people can have rashes, muscle aches. Less commonly, you can have diarrhea or stomach pain due to inflammation of the stomach or the intestines. People can develop low thyroid by inflammation of the thyroid, hepatitis by inflammation of the liver, kidney damage by inflammation of the kidneys, heart damage rarely, or lung problems such as inflammation of the lungs, pneumonitis, where you can have a cough, shortness of breath, low-grade fevers, and in some cases you need steroids. In rare cases you need hospitalization, and certain autoimmune conditions can happen. Like I mentioned, thyroid can happen. You can cause basically autoimmune thyroid disease with it. You can cause certain pituitary disorders. If it attacks the islet cells in our pancreas, that's where we make insulin. You can get diabetes from it. That's very rare, but it can happen. It's not very common. And so it's just important that you know that what I tell most patients, I have excellent medical oncologists that I work with, but I tell them that inflammation can happen anywhere in the body. So to take it seriously, it can sometimes happen months later, even after treatment's discontinued. So you need to let one of your doctors know about this so that we can effectively manage it. Distress is pretty common in patients with cancer, and anxiety and depression can happen. So you should know about this Open Options program, which is a support counseling program, helps you prepare for an appointment. The number is here, and is a great resource to take advantage of. Journaling, I talk a lot about Headspace, which is an app on the iPhone. That's a really great way to relax and meditate. Um, Going on walks with family and friends is important. And sometimes just writing down your own ideas and words of what you're going through can help you deal with the significant stress that cancer can entail. And make sure you talk to us about it. You know, what I tell my patients commonly is I'm not here to just take care of, you know, the tumor here or wherever it is. I'm here to take care of you. And that's how everybody on my team is. And that's how I'm sure your cancer doctors are too. So we need to know about that. And we have a whole host of resources for the cancer support community that can help you. And family support is really important. Some people feel like they don't want to be a burden. They don't want to cause extra, you know, hardship. But that's the crutch that we lean on in, you know, when we're sick. So loved ones want to help. So let them know, and they're usually there to be there for you. So by improving your activity, making sure you eat well, maintaining good relationships, you can find that the journey, getting through the journey will be much easier. And so immune therapy is extremely exciting. It's still a new field and is progressing every day, but is really an exciting potential treatment option for you. So make sure you ask about it. There's a lot of great resources online, and our cancer support community resources are here. They're very accessible and a lot of different languages here. So we have a cancer experience registry, which helps try to identify and understand the emotional and social needs unique to your cancer experience. And it helps us make sure that we provide the best quality of care possible, and it's completely confidential. And it's been available for many different types of cancers. And so this is how you can join. You can go to www.cancerexperienceregistry.org, and in 3 steps, first agree to join the registry, give your email, and completing a profile and filling out a survey. And you can get new resources to help you on the journey. And advocating for this is also important. Money for cancer research and advocacy is critical to make sure that patients not only get the best treatment, but get supported along the way. So I encourage you to advocate for this extremely important cause. And another resource is mylifeline.org, which provides blogging, discussion boards, care coordinators. There's another outstanding resource. But that's all I have to say for now. And thanks so much for having me. And I'm happy to take any questions at this time.